welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Happy Monday and welcome to Brain Chat, everybody. It's Dr. Mitzi, your board certified neurologist. I am so excited to talk with you guys tonight. I don't know about you, but here in Georgia, we had spring break last week. So the kids were out. We got a little fun. We got a little sun. And now it's back to the grind. So you know how we do on Brain Chat. Type in the comments where you are viewing us from. I bid you greetings from Atlanta, Georgia, where yesterday it was in the 70s and today it's in the 40s. So this weather has been really, really crazy. So I've got an amazing guest with me tonight, Dr. Robert Shin, and we are going to be talking about visual changes in the visual system with the MS. You know, one of the interesting things about MS is that some of the most common symptoms that people start with are vision problems. So some people have loss of vision, something called optic neuritis. We're going to get all into it and we are going to talk about it tonight, and we're going to have fun doing it. So I see a couple people logging in. I see someone from Tulsa, Oklahoma. Okay, I think that's my first Oklahoma viewer. Somebody from Southfield, Michigan. All right, so you guys know. And if you have any questions throughout the podcast or throughout the Facebook Live, please type them in the chat, and we'll have a little bit of time for Q&A at the end if we have some time left over. I also want to say thank you to our sponsors. Our sponsor, Janssen. And if you want more information, you can visit more2ms.com. All right. So thank you to our sponsors. All right. Perfect. So let's go ahead and let's get the party started. So coming up to the platform, I have Dr. Robert Shin. He's a professor of neurology and also a director of the MS Center at Georgetown University. Dr. Shin, welcome to Brain Chat.
Hey, thanks for having me, Mitzi.
Absolutely. Absolutely. So, I have to bring all the energy because it's Monday, so I have to kind of keep myself hyped up. So let's talk about vision. But first, tell us a little bit about yourself and tell us how you got into dealing with MS and about your background with ophthalmology, et cetera.
Sure. Yeah, I actually, since you brought this up, my first interest was in vision. So I trained in neurology at the University of Pennsylvania and did a fellowship in neuro-ophthalmology, which is the neurology of vision, basically studying how the optic nerves and the brain process vision. And what was happening in the late 1990s was this recognition, just as you mentioned, that so many people with multiple sclerosis have a visual problem, if not as their first kind of presentation, but certainly along the course of their life living with MS. And so, as I'm sure your listeners are aware, in the 1990s is when we first had treatment options for MS. Kind of amazingly, we couldn't even treat MS before the early 1990s. So then there was a lot of interest in figuring out, well, how do we recognize people with multiple sclerosis, identify them as early as possible? And so I did another year of training after my neuro-ophthalmology year, focusing in on MS. And it's been actually a great kind of complement, seeing individuals with visual issues, seeing people with multiple sclerosis, and, people with both, which turns out there are a lot of them.
Absolutely. So a lot of patients come to us from the optometrist, from the ophthalmologist, or from the neuro-ophthalmologist. So this is right in line with what you were interested in. I'll tell you the truth. When I did the visual system, I was like, okay, everything is crisscrossing and okay, I can learn it, but I don't know if I can totally focus on it. So, so grateful that you have that extra knowledge and expertise, which is amazing. So let's kick it off and let's talk about optic neuritis, one of the most common symptoms that we see when people are initially diagnosed with MS. What is optic neuritis and how does MS cause optic neuritis?
Well, optic neuritis, the words themselves basically mean inflammation of the optic nerve. But I have to be honest and say, when we use the words optic neuritis, we're being very specific. We're almost always talking about inflammation being caused by demyelination in the optic nerve. So each of us, obviously, typically we have two eyeballs. Each eye is connected to the brain by a cable, the optic nerve. And if that nerve gets inflammation, there's going to be trouble with vision. You're going to have difficulty seeing. Now, I would emphasize that although people with multiple sclerosis often have optic neuritis, in fact, it may be the first symptom they ever experience. You can have optic neuritis for other reasons, or sometimes it can just happen by itself. So even though optic neuritis can be, we would say, idiopathic, meaning just by itself, it can be associated with different conditions. But you're absolutely right. Optic neuritis and MS are clearly linked.
Mhm. Yeah, so a couple things that you said there. So one thing that definitely stood out was, that the optic nerves are affected by MS, and the optic nerves are actually part of the central nervous system. So, when we think about the central nervous system, which is affected by MS, we mostly think about the brain and the spine, but it's the brain, the spine, and the optic nerve. So that's kind of a little trick there, to make sure that we recognize that's part of the central nervous system, which is often affected. And then in terms of, optic neuritis being caused by other things, let's talk about this old trial, not old, but it still has updates, called the Optic Neuritis treatment trial, right? So, because we know optic neuritis is a very common first symptom of MS, there was this large trial that they're still publishing results from to try to figure out, okay, if someone has optic neuritis, who's going to go on to have MS versus who is going to, maybe not have another symptom or another problem that needs to be treated with medications like we treat for MS. So, can you tell us a little bit about that study?
Sure. Well, the optic neuritis treatment trial was so impactful because it was really the first time we looked at optic neuritis and how to treat it in a detailed way in a controlled clinical trial. Because optic neuritis as a phenomenon where someone would lose vision in one eye, usually, actually, there can be a little bit of pain or discomfort, especially when moving the eye. That had been described for actually, probably over 200 years. Some people think that maybe even in antiquity, even maybe in the Bible, people might be describing an episode of optic neuritis. So we'd
Wow.
known about it, but we weren't really sure how best to treat it. And your listeners should be aware that, let's say, if you go back to the maybe 1970s or 80s, we thought we knew, well, if you have inflammation of the optic nerve, and it's causing you to lose vision in one eye and it makes the eye hurt because of the inflammation, people were using corticosteroids, things like prednisone, to treat the optic neuritis because it made sense. If there's inflammation, and we know that corticosteroids reduce inflammation. And actually, I have to tell you, many people that observe, hey, when you do that, some young person comes in, they're like, oh, it's weird. I thought there was a smudge on my glasses or something. I'm having trouble seeing and my eye hurts when I move it. And you say, oh, you might have optic neuritis. And you give them some prednisone. They'll call you back to, oh, Dr. Smith, like, oh, that helped so much. The pain went away. I think my vision is coming back, and they get better. So it just
Right.
seemed like, well, prednisone does seem to help, and it seems to presumably reduces the inflammation. Other things had been looked at, actually, even surgeries, because it's sort of an anatomic thing, but the optic nerve travels through the skull. You said the optic nerves are part of the brain, essentially, and it's true. But, it's almost like the brain had to like squeeze out through the skull to get to the surface so it could see light. So the optic nerve travels through the optic canal, which is a very tight tunnel of bone. And so some people
Mhm.
said, well, if the optic nerve is swollen, it's going to choke that nerve. So maybe we should operate and kind of decompress. Anyway, there were just a whole bunch of different ways people were trying to treat optic neuritis. Now, the optic neuritis treatment trial said, we should examine this scientifically. We need to do a study where we have a control group who's going to get a placebo, meaning basically a sugar, like nothing active, versus people being given prednisone. And then actually, they also wanted to try a very high dose regimen, which would be intravenous methylprednisolone, which was basic corticosteroids, but on steroids, if you will, like much more powerful.
Steroids on steroids.
Yeah. So it was interesting because when that trial was proposed, there were some people who said, this is kind of unethical to even do this study because obviously prednisone, we've been giving people with optic prednisone, they get better, their pain goes away. Why would you randomize people, or why would people volunteer for a study where they might not even get treated. They might get a placebo. And, it seemed like some people said, we know it works. Why do the study? But really, I guess I would say the scientific establishment prevails. Said, we don't technically know whether steroid treatment with prednisone is really better than leaving it alone. We need the study. So there were 3 arms. People in the Optic Nerve treatment trial were either randomized to get pills that turned out to be placebo pills, or pills that turned out to be corticosteroid prednisone, or they were given 3 days of IV steroids, and then the rest of the days were pills, basically. So that was sort of the arm. And the surprising result of the optic neuritis treatment trial was that all 3 groups did exactly the same. They all ended up with the same vision at the end of the study. It didn't matter whether you got placebo or prednisone or even the IV corticosteroids, your visual recovery was almost complete regardless. Because it turns out what we did not realize is that optic neuritis almost always gets better on its own. It just takes a few weeks of time. So all of that time that we were giving people prednisone, they got better. It's because, they were getting better.
They
and
were
it
going to
turned
get
out,
better.
yeah, they were going to get better anyway. And we were just in a way kind of fooling ourselves. Now, I will say that it did seem as though people who were given the intravenous corticosteroids got better faster, meaning they got to that good vision more rapidly than if they were in the placebo or in the prednisone group. But the other kind of actually surprising thing, which has been verified, is the people who were given the prednisone, which remember was essentially the standard of care, was the default treatment. Weirdly, they had an increased likelihood of having the optic neuritis come back again, like almost rebound on them. You'd actually have been better off not treating, getting the placebo rather than being treated. So it really was a very surprising result in terms of the outcome, meaning that actually it doesn't really matter whether you treat optic neuritis or not. It generally gets better. However, again, you can speed that recovery up with IV corticosteroids or methylprednisolone. Now, you say, well, that's kind of interesting, but what does that have to do with MS? Well, the other thing that was actually kind of interesting was they discovered that, a lot of people with optic neuritis end up having another clinical event and being diagnosed with multiple sclerosis. It's just the optic neuritis might have been one of multiple episodes. And at first, it looked like if you were given IV corticosteroids, it looked like you were less likely to get MS, that it was less likely for you to have a second event. Now, on follow-up studies, as they continue to follow people out for 2 years or 3 years or so, then it turned out actually it looks like if you have MS, you're going to have that second event eventually. But it did look like the IV corticosteroids not only sped up recovery, but maybe delayed that second event for a little bit. And this is sort of maybe the third lesson of the optic neuritis treatment trial. Everybody in the optic neuritis treatment trial was given things like had lab work and had an MRI, and they saw actually a very strong association, even though it actually didn't matter which group you were in, placebo, prednisone, or IV steroids, in terms of visual outcome. 90% of the time, you're going to get normal vision back. What was very different was if your MRI showed spots, had demyelinating lesion on the brain MRI, nothing to do with the optic nerve, just sort of incidentally other spots that look like MS, you were much more likely to be ultimately diagnosed with MS than if your MRI was normal, other than the optic nerve issue at the beginning. And that's when we started to use this term, clinically isolated syndrome, saying, you could show up with a single event like an optic neuritis. Technically, back then, you had to have 2 episodes to have multiple anything, right? Multiple sclerosis would have to be more than 1 episode. But if you had a single episode of optic neuritis and your brain MRI showed some, spots that looked suspicious for MS, we recognize that as, although technically at the time we didn't call it MS, we said, if you have a clinically isolated syndrome, there is a really good chance you might have MS. We should watch you closely. And that ultimately led to a series of treatment trials looking at the treatment of clinically isolated syndrome.
I mean, you said so much good stuff. So let's rewind for a second and go back to those corticosteroids, right?
All right.
Because this is really important when we talk about optic neuritis, when we talk about relapses with MS, right? Which are those new or significantly worse symptoms, last at least 24 hours, no infection, no heat, no super stress, things like that. So, what I try to convey to my patients is exactly what you described, right? That people are going to get from point A to point B. Steroids help you get to point B faster, but don't necessarily make you overshoot and get over here to point C, right? And I think that that's something very important. Like some relapses don't necessarily need to be treated with steroids because steroids do have some side effects. So I think it's very important that we convey, that they may speed up recovery, but they don't necessarily make you overshoot and recover more than you would if you had not gotten them. Any thoughts about how you kind of educate your patients on that? Because sometimes people are like, oh my God, I need those steroids. I got to get them right now, or something's bad going to happen if I don't get them at like 3 a.m. And I'm like, well, let's back up a little bit. We don't necessarily have to get them at 3 a.m., right? We assess,
Right.
but the goal of them is to speed up recovery.
Yeah, I have to be honest and say that I have mixed feelings on the subject. On the one hand, I agree
Hmm.
with you completely. People should be aware that the data suggests that the outcome is going to be usually pretty good, to be honest with you, regardless of whether or not you receive corticosteroids. Because occasionally I've had patients who come to me and they tell me, oh, I had an episode of optic neuritis and I was never given any treatment. And they worry that maybe they missed out on something, or maybe there was some permanent damage done, and they just feel really bad about that. And I try to reassure them, as you do, like, no, that probably didn't alter the outcome in any significant way. Having said that, I think even if corticosteroids primarily speed up recovery, that can be of value, depending on how severe the symptoms are. I think I agree with you. If it was maybe just a subtle sensory symptom, a little bit of tingling, and it wasn't too bothersome, one might argue, is it even really worth the risk of steroids to try to speed up that recovery? But somebody with severe vision loss, severe eye pain, maybe somebody with significant motor symptoms or imbalance, one might argue the faster we can help someone recover, the better. And then the last element that I grapple with a little bit is, I'm sure you've covered this on some of your other shows, is the increasing recognition that there can be subclinical damage that's occurring from the beginning of the disease. And so I find myself
Hmm.
wondering, even though I 100% agree with sort of your formulation, but should I be a little more aggressive? Should I be trying to suppress the inflammation as quickly as possible? Because whether or not it's immediately clinically obvious, I think you and I both agree our job is to preserve brain for our patients as
Absolutely.
much as possible.
Absolutely, and I agree with every point that you've made, and so, oftentimes I do wind up treating, I definitely am probably more on the aggressive side because I do
Mhm.
want people to feel better faster,
Right.
but at the same time, when we think about treatment being an emergency, it is urgent, but not necessarily in the same sense as if you wake up at 3 and your chest is hurting and you're having a heart attack, emergent, you know what I mean? So I think that, I try to balance that, but certainly I want people to get better as quickly as possible. But I do also try to balance that information with the fact that, we don't have clear evidence that will make you overshoot or get 50% better if you get the steroids versus if you don't get the steroids. So, it's something we're still learning, right? Science is
Absolutely.
imperfect, and so I definitely want to bring out that point. And then the other point was about, looking at that group that has the potential risk for going on to have more symptoms that are indicative of MS in the optic neuritis treatment trial. I feel like this really revolutionized the way that we treat MS because we used to kind of wait for something else to happen before we would diagnose you, so you had to have 2 episodes, right? For some people, those episodes may be 5 years apart. Sometimes I've had people where they've been 10 years apart, and then we kind of moved the needle back a little bit and said, okay, if you have an episode and you have spots on your MRI, then we'll wait until you have another spot on your MRI, right? And then you've got MS, and so I feel like really kind of this creation of this classification of clinically isolated syndrome, which we don't really use anymore because we just call those people MS now, has really allowed us to move that needle back and diagnose people earlier and earlier and start treatment earlier so that we don't have to continue to allow that damage to go onto the brain while we're waiting for something to happen either on MRI or for them to have another symptom. Any thoughts about that?
Well, I do think it is fascinating how our understanding of early MS has evolved in this time period, as you just mentioned. In that time, back then, as you just mentioned, by definition, you needed to have more than one clinical episode to be diagnosed with multiple sclerosis. In fact, we learned a lot because, let's say in the United Kingdom, where they have a national health system, they were very strict, very rigorous. If somebody showed up with optic neuritis, didn't really matter how the MRI looked. They were very strict and said, you cannot be given MS medication unless you've had a second event. That actually taught us something because by following people with optic neuritis for years, 5 years, 10 years, 15 years, even 20 years, what we learned from the English, British, UK experience was that if you have an initial event of optic neuritis and you have spots on your brain MRI, 80% of the time, if we wait long enough, you're going to have another attack. And then we'll call it MS, but one might argue, but we let that attack come through. On the other
Mhm.
hand, if you had an optic neuritis, but your MRI was stone cold, otherwise normal, the chance that you were going to have an attack if we just kept an eye on you was really more like 15%, 85% of the time. And that wasn't zero, and it wasn't 100% on the other end, but there was a huge difference in your risk based on how that initial MRI looked.
Right.
Now, the other thing that you actually just mentioned, which is, important for your listeners to understand, is we in the MS field have changed how we diagnose multiple sclerosis so that somebody could have a single event, an optic neuritis. Now, if we look at the MRI and I see lesions or spots in 2 out of 4 classic areas, periventricular, juxtacortical, brainstem or cerebellum, infratentorial or spinal cord, and I see some spots are old. They're like scars. They're inactive, but some are active or gadolinium enhancing. We're just like you just said, that's MS. Like we don't even have to use this term clinically isolated syndrome. We don't have to wait for another episode to happen. I see old and new scars or spots, and I see spots in multiple areas. That's enough. We're going to just take action. Now, there is still maybe a small number of individuals who might have an initial episode. Maybe they have some MRI lesions, but maybe I don't see any gadolinium enhancing lesions. Maybe I did a spinal tap and I didn't find oligoclonal bands. So they don't quite meet our criteria for MS. So there is still, I think, a use for the term clinically isolated syndrome for someone with a single event who does not otherwise meet our new
Criteria.
modified criteria. I would
Mhm.
actually argue personally, I probably wouldn't start MS medicine on someone like that because,
Right.
again, that's sort of by definition, they didn't quite meet our criteria for it. But I'm definitely going to watch that person closely.
Yeah.
One lesson we've learned through this whole process is that MRI is a great biomarker for disease activity. We've learned that for every one clinical symptom, one clinical attack that you might notice, you can have up to 10 spots show up in your MRI that could have otherwise been silent. So using MRI, and this is why a lot of people living with MS, there's like doctors getting MRIs all the time. It's like, why? Well, because it's useful. It helps us identify activity before the MS starts to, affect things. And so again, just the evolution in how we address this has just been remarkable over the past 10, 20 years.
Absolutely. And so the MRIs have been, in a way, kind of a blessing. And in some cases, they could be a little bit of a curse, right? Because when we look at those spots, now people get MRIs for all kinds of reasons, right? People have headaches, they get MRIs. You could pretty much put, I remember a time when I used to order an MRI and the radiology department would call me and be like, do you really need this? Like, this is an expensive test. Like, make sure you need to order this. Or they would say no, but now you can really get an MRI for just about any reason. So now you have folks who have, maybe an episode, like you said, some spots that look like they may be from migraine or maybe related to high blood pressure, and so we do have this conundrum about what to do with those folks. And then another thing that I try to explain to my patients is that, there are places where we look for typical spots related to MS, but the only way to tell 100% what a spot is to do a biopsy, which we're not going to do, right? So we have to make our best educated guess based on where the spots are located, but we don't have 100% that says this one spot here is a demyelinating spot and this one spot here, is, from microvascular disease from your smoking or what have you, so we have to look at the data, make our best decision. But sometimes, especially when the spots don't look typical, we have to continue to watch people very closely to see if we can figure out what's going on. And before we go on to talk about other vision symptoms, one more thing, since we're talking about MRI, we're talking about diagnosis. Let's talk about RIS, which is radiographically isolated syndrome, right? So we're taking a step back from CIS, which is that first episode, of symptoms that look like MS. Now, there are some people that come in and let's say they're in a car wreck. They get an MRI, right, for something totally unrelated. They've had no symptoms, but they have a brain MRI that looks like MS. What do we do with those people?
Well, that's, as you pointed out, been something we've been grappling with because MRI is becoming ubiquitous. People are getting MRIs whenever they have a headache, whenever they have a car accident, maybe possibly have a concussion, maybe even children playing soccer or football. They can have an accident, and just to be extra safe, we'll do an MRI scan. And because we're doing so many scans, we are sometimes discovering individuals who have spots on the MRI that look a lot like MS. They look suspicious for MS. Now, unlike someone with a clinically isolated syndrome who had some event, an optic neuritis or a brain syndrome, spinal cord, they had one presentation and their MRI is suspicious. We're talking about someone who've had technically 0 episodes. They just happen to get an MRI for another reason. So what do we do with that? Before, if you had one, we would say, well, you would need to have 2 episodes before we call it MRI. Now we're like, okay, if you've had 1 episode, but there's enough, if there are enough factors on the MRI, I'll count that. But now what if you had zero episodes? What do we do? I'll just say, I think the field hasn't quite decided what to do about that. There are some studies that are going on now trying to make different criteria, different guidance as far as how to manage that. I think most of us definitely would consider following that individual with MRI. I think the real question would be, what if you have someone who's had no episodes, you happen to pick it up, these spots on MRI, and then you did a follow-up MRI and there was a new spot or an enhancing lesion. They've still not had any episodes. What are we going to do with that? I mean, I can tell you my private thinking is I would probably still consider that MS. I just said that we know that MS can be sneaky and you could have areas of inflammation without a symptom. So, but I'm just saying that personally, I might go that way. We don't have, I think, a definitive story for that. I was going to add one more thing. As you pointed out, the MRI spot or the spots on the MRI can sometimes be hard. It's hard to pinpoint because MS patients have spots, but having spots on your MRI doesn't automatically mean you have MS. There are a lot of other reasons that you can have spots, like, as you said, migraine, just getting older, high blood pressure, diabetes, any number of things. Maturity and wisdom. Wisdom can do it.
Gray hairs, gray spots.
I have a little coaster. It says, "I don't have gray hair. I have wisdom highlights." My kids gave that to me.
I need that. I've got lots of highlights.
Perfect. But the future might help us with that, because I think this would be a separate conversation. But there are more advanced techniques on MRI looking for things like central vein sign and factors that might actually allow us to more definitively tell an MS spot from a non-MS spot. But that's for the future. So again, RIS, radiologically isolated syndrome, still a challenge. I don't think we've quite figured that one out yet.
Yeah, yeah. Thanks for your perspective on that. All right. Okay, so we digress, but back to the vision. All right. So now we talked about optic neuritis. We talked about, the brain squeezing through the eyeballs, so we can get out there
Yes.
and see the vision. Let's talk about the symptoms. So we talked a little bit
Mm.
about it, but what are the common symptoms of optic neuritis, right? Sometimes people come in and, they may already have MS, but maybe have never had optic neuritis. And they're like, oh, my eye is tearing up. My eye is red, all kinds of things.
Mhm.
So people can think that anything that's wrong with their eyes is optic neuritis. So, what are symptoms of optic neuritis?
Well, the most classic symptoms of optic neuritis, I sort of hinted this along the way, will be blurring or loss of vision, typically in one eye at a time. It'll usually be the left eye or the right eye, and it'll be blurred. It can start out, some people feel like there's just a smudge in the center of vision. I had many people say, I thought I got something on my glasses. I just thought I had a smudge on my glasses, or I thought my contact lens was dirty. But it could be quite severe. That could be quite a large degree of vision loss. Often there can also be a loss of color perception, or lights or colors may seem more faded. And another feature I hinted at is when you move the eyes around, there can be some aching or discomfort, or almost like a sticking, prickly feeling behind the eye. Keep in mind, the eyeball obviously moves around. Our eyes move up, down, left, right, and can even twist. The cable on the back has to be kind of flexible. It has to have some slack so that when you move the eyeball, the nerve can move too. But imagine if that nerve is inflamed and you're moving the eyeball, you're kind of like wiggling the nerve. You can have some discomfort there. So blurred vision or decrease in brightness and color vision, pain on eye movements. These are sort of the most common subjective symptoms someone might experience with optic neuritis. Now, you mentioned other things when but what if the eye just looks like, you look at the eyeball, there's like blood in the eye, that can look scary, or maybe it's pink or weepy or something. To be honest, that's usually not optic neuritis, because optic neuritis is behind the eyeball. You sometimes hear this term retrobulbar optic neuritis, retro
Mhm.
behind, bulbar, the globe, the ball of the eyeball. Optic neuritis, meaning that it's behind the eye, so you wouldn't see anything on the front of the eye. In fact, we used to say something, if the patient sees nothing and the doctor sees nothing, like I'm looking at the eye and it looks fine, you got to suspect optic neuritis, because you're going to have vision loss, but the eyeball is otherwise going to look fine. So all the other stuff you should still see an eye doctor for. If your eye is
Right.
red or bleeding
Right.
or weepy,
That's
get
not
it checked
normal.
out.
Go to the doctor, but that's probably not optic
But
neuritis.
it's
Yeah.
probably not optic neuritis, exactly.
Okay, so now let's talk about a condition that's very similar to MS. So we talked about some of the things that can also cause optic neuritis, but let's talk about a condition that's very similar to MS that also causes optic neuritis, neuromyelitis optica spectrum disorder. It's got a lot of
Mm.
extra letters now. So what's the difference between optic neuritis that we see with MS versus optic neuritis that we see with NMO?
Well, I tried to be careful earlier when I said sometimes optic neuritis just occurs by itself. But sometimes it can be other disorders or MS. And you brought up some of what are those other disorders? Well, for a long time, actually, we didn't even realize that there were things that could mimic MS, that could cause demyelination of the optic nerve, could cause vision loss, just as I described from optic neuritis, but maybe isn't multiple sclerosis. And it took us a long time before smart people, scientists at the Mayo Clinic, discovered that, some people who have optic neuritis, or maybe demyelination of spinal cord transverse myelitis, or maybe other kinds of maybe unusual brain lesions, or even this weird thing where the people have hiccups or nausea and vomiting and it's not really explained, they might actually have a different condition. It looks like demyelination of the optic nerves, brain, and spinal cord, but it's associated with antibodies in the blood. That if you draw blood, you will find antibodies to something called aquaporin 4. Aquaporin is basically a water channel, aquaporin. So aquaporin 4 antibodies are expressed on this other cell type called astrocytes. But when you have antibodies against aquaporin 4, you can have a syndrome of optic neuritis, transverse myelitis, brainstem disorder, sometimes even brain lesions. And it can overlap quite a bit with MS. And so the term, as you mentioned, we call it neuromyelitis, myelitis being spinal cord, optica, referring to the optic nerve, neuromyelitis optica spectrum disorder, because it can overlap in this sort of wide spectrum with what we recognize as MS. How do you tell them apart? Well, there can be subtle clues, but the biggest way is that blood test I mentioned. If you
Mhm.
find antibodies to aquaporin in the blood, they have NMO spectrum disorder. People with multiple sclerosis would not have those antibodies. So there are other subtle differences, but honestly, it took us a while to realize that they were separate disorders. When I was in training, I was taught that NMO was simply a variation on MS, an
Me too.
unusual variation that seemed to affect the optic nerves and spinal cord and somehow spared the brain. But we now realize that it's its own condition. In fact, the other thing I was taught when I was in training is that if you go to Asia, if you go to Korea, Japan, China, I was taught that Asian people don't have MS the way people in America and in Europe have it. That in Asia, I was taught they have MS that primarily affects the optic nerves and spinal cord. We called it opticospinal MS or Asian MS. Well, come to find out, in retrospect, it should have been obvious. That's just NMO spectrum
NMO.
disorder. Yeah, that NMO can occur. It doesn't matter what race you are or where you are on the planet. You might develop antibodies to aquaporin 4. And it is, I'll be honest, a lot more rare than MS, but we're increasingly finding it and recognizing it. We're even discovering that some people that we thought had MS actually have NMO once we start checking for the aquaporin 4 antibodies. So that's been a big
Right.
change in our field, I would say.
Yeah, absolutely. I agree. I learned about, the Asian variant of MS as well. And, also when we think about other populations, like for instance, the Black population, we also learned that Black people have more optical spinal MS, but Black people have more NMO spectrum disorder as well. So, again, one of the humbling things about science is that we're always learning. We're always learning. We're always, trying to make sure that we're doing the best for our patients. So, what other vision changes can happen with MS? So we talked a lot about, optic neuritis, which is inflammation of the optic nerve, but, the visual pathways go all the way through the brain. So what are some of the other common symptoms or visual changes that we see related to MS, like double
Sure.
vision or intranuclear ophthalmoplegia or INO? Tell us a
Right.
little bit about those.
Sure. Well, actually, before I leave the optic the one last thing I want to mention is besides NMO spectrum disorder, there's yet a newer condition called MOG, antibody-associated disorder, MOGAD, which is also
Yes.
it's also pretty rare. But again, just so your listeners know, we're just learning so much about these conditions and realizing that our job is to actually sort them out, to figure out what's MS, what's NMO spectrum disorder, what's MOG, antibody-associated disorder. So, but that's all on the optic neuritis side. Now,
Awesome.
optic neuritis is, again, the input side. That's like from the eye going into the brain through the optic nerve. But at least humans have a lot of brain and brainstem machinery dedicated to eye movements because we have two eyeballs, but they have to move together. If I look left, right, up, down, my eyeballs have to move together. And if they don't move together, I'm going to get double vision because the eyeballs are pointing in different directions. Now, MS doesn't just affect the optic nerves. It can affect some of those important pathways that keep our eyes connected. So you mentioned a really common scenario where there's a path within the brainstem called the medial longitudinal fasciculus, Dr. Stuff, MLF. But that highway is an important connection between our two eyeballs, basically, to help them move together. And if MS causes demyelination that affects that structure, now suddenly our eyeballs don't move together. If I try to look to the right, maybe my right eyeball looks to the right, but my left eyeball doesn't get the message. It sort of stays, let's say, straight ahead. Now I've got one eyeball pointing to the right, one eyeball pointing straight ahead. Now I'm getting double vision. I'm seeing two different things. We refer to that disconnection between the two nuclei, as you said, an internuclear ophthalmoplegia or INO. I'm going to tell you and tell your listeners that there are very few disorders that can cause an internuclear ophthalmoplegia in isolation other than MS. I mean, it's rare, it could happen, but it's very suspicious for MS. And actually, sometimes it's bilateral. Imagine if I look to the right and one eye goes to the right and the other doesn't, and I look to the left and one eye looks to the left and the other doesn't. Now I've got bilateral internuclear ophthalmoplegia. This, again, can cause quite a bit of double vision, which is kind of a hallmark of MS. And then the third kind of other visual thing I'll mention also has to do with eye movements. But sometimes MS will affect the brainstem in a way that the eyes aren't really able to stay still. So the eyes are
Mhm.
wiggling or shaking. And we refer to that rhythmic movement of the eyes as nystagmus. That's our term for that. Now, if you have nystagmus, you may not get double vision, but what's gonna happen if your eyeballs are moving? It's gonna be like your whole visual world is shaking, kind of like the old days before we had all of our cameras have motion stabilization now. But remember the old days with the Super 8s or like the birthday party where like you can't even watch the movie because it's shaking so much just from.
Ah,
Well, that shaking of the visual world we call oscillopsia. One of my favorite words because it sounds cool. Right?
that's a
Oscillopsia.
pretty cool word. It's a pretty
Pretty
cool
cool
word.
word.
Yeah.
Oscillation, like an oscillating fan moving back and forth. Opsia vision, basically shaking vision, is oscillopsia. So, besides optic neuritis, you can have double vision from something like internuclear ophthalmoplegia in MS, or you could have shaking vision, oscillopsia, that's due to movement of the eyes called nystagmus. So yeah, absolutely, MS can do lots and lots of things to your vision.
So, what about addressing visual problems with MS? How are there some of these problems that we can treat? Or should people be seeing ophthalmologists on a regular basis, whether or not they have visual changes? Kind of what's some of the guidance that you give your patients in that regard?
Sure. Well, all of us actually, I think, should see an eye doctor about once a year, regardless of whether you're living with MS or not, because eyes are important. And I think, as your listeners know, having MS, unfortunately, doesn't magically protect you from just regular old stuff, like
Right.
developing cataracts or making sure that, watch out for glaucoma or things that are treatable but need to
Right.
be identified.
Right.
Now, if you have one of these neurological symptoms, optic neuritis, maybe an internuclear ophthalmoplegia causing double vision, or maybe nystagmus causing oscillopsia, any of these visual issues, yes, it would be great if you can be seen by a neurologist or neuro-ophthalmologist. There are not a lot of us, but we are out there. Only maybe for counseling and also to look at, are there different things we could be doing? Now, I will just say, because I know we're kind of running short on time, that there might be different things I would try to do depending on what the exact visual issue is. But I would actually circle back, and I'm sure this has been covered in some of your talks about just MS treatment in general, being any episode of visual dysfunction to me means essentially it's a type of relapse. So I'm going to ask myself the question, can I be doing better? Should we be talking about a more effective MS disease modifying therapy? Or,
Right.
have I perhaps, maybe I didn't prescribe a good therapy that you could tolerate well, so we're missing doses, or, basically an episode of visual dysfunction is like any other MS relapse. We want to address it and help you recover, but we also want to pay attention to the implications of having MS activity, which is that, I think we should look for an even more effective therapy.
Absolutely. Absolutely. And well said. And as you said, we are running short on time. Man, this has gone by so fast. What an amazing conversation. I mean, I learned something. And I learn something every time from my amazing colleagues when we do these shows. I will ask if the audience has any questions, if you can pop them in the chat, and the explanation of the different symptoms, I think, was spot on. I probably couldn't have explained it better. And I think this information is so valuable for people because it's important for people to be aware of what's going on with their MS, and aware of, kind of when we decide or what is kind of our trigger to say, okay, well, maybe we're not doing the best we can in terms of therapy. Maybe there's something we need to switch. And so I'm very much an advocate for empowering patients and empowering their loved ones and care partners to be sure that we have treatment conversations at every visit, right? It's a continuous discussion. Like, are we still doing good? Are we still having more trouble? Should we keep going in the same vein or should we switch gears? So I don't think we have any questions. So why don't you just give us some parting thoughts, Dr. Shin, as we get ready to close today's broadcast?
Well, I actually didn't say this earlier, but maybe your
Mhm.
listeners should be aware that the vast majority of people living with MS are going to have some type of visual issue at some point. If it's not the initial episode, it could happen later on in their life with MS. Some studies have said that 80% of people living with MS are going to have some form of visual issue. The main thing I would say is, of course, don't ignore any kind of visual issue, blurred vision, double vision, shaking vision. Please reach out to an eye doctor. And if you have access to one, reach out to an ophthalmologist so we can try to address that for you. And again, as Dr. Williams just said, so we can also factor that in to our treatment decisions. So, hey, thanks for having me on
Absolutely.
the show.
Amazing. Thank you for coming on Brain Chat, Dr. Shin. And thank you all so much for watching. Make sure you subscribe to the podcast, Brain Chat with the Nerdy Neurologist. This will be posted in a couple of weeks on all platforms, Spotify, Apple Podcasts, all that great stuff. And we will see you in 2 weeks. All right. Good night, everybody.
Awesome. Good night.